Assalamu alaikum. Good evening, everyone, and welcome to today's webinar, Medication Safety and Polypharmacy, organized by the Saudi Patient Safety Center in collaboration with WHO IMRO. First, let me introduce myself. I'm Ala Al-Umari, Patient Safety Specialist. I will be responsible for hosting this session. Today's session will last for 60 minutes. The last 15 minutes will be for the Q&A part. Before we get started, I would like to go over a few tips so you know how to participate in today's event. You will have the opportunity to ask a question for our presenter by typing your question in the Q&A panel. You may send your question at any time during the presentation. We will collect those questions and address them at the end of our session. I would like now to welcome our speaker for today, Dr. Alpana Meyer. She is the head of effective prescribing and therapeutic for the Scottish Government, responsible for advising ministers on quality, prescribing safe and effective use of medicine. She is the principal investigator and coordinator of the Europe-funded project Sympathy and Empathy. She is the responsible for development of a Scottish National Polypharmacy Guidance and Quality Prescribing Guideline for health providers and patients with patient app and shared decision-making tools. Alpana leads work for the WHO on polypharmacy and an expert advisor and consultant for the WHO Geneva and IMRO region on patient and medication safety and for the Europe-funded PMR projects. She is the lead for the Scottish Government work on international development supporting Malawi and Zambia at health ministry level, addressing patient and medication safety as a part of their national program. Dr. Alpana provide a leadership for International Foundation of the Integrated Care, coordinating the special interest group on appropriate polypharmacy, multimorbidity and adherence, and she is the Europe coordinator for work on active and healthy aging on polypharmacy and adherence to treatment. She is an associated professor at the Edinburgh University, honorary clinical fellow, and affiliate of the Asher Institute, Edinburgh University. She is the lead clinical pharmacist at the Homeless Practice, establishing pharmacy outreach services in Edinburgh, and was previously the Deputy Chief Pharmaceutical Officer for and our Albania, if you please.
Thank you very much for the warm introduction. So I'm going to talk to you today about medication safety in polypharmacy and how we might go about starting the work in reducing the harm from inappropriate polypharmacy. So briefly, what I'm going to cover in today's session is defining polypharmacy, to present some initiatives and regulation and policies and experience undertaken that are related to polypharmacy in the context of medication safety, think about contributing factors and possible risks, and possible strategies that may be used to address inappropriate polypharmacy, and thinking about what resources might be also used in low and middle income countries to try and enhance addressing this important issue. I'm sure this data is familiar to many of you, the fact that we have an aging population. So if you look from the left-hand side to the right-hand side, our journey from 2015 to 2050. This is a large contribution in terms of improvement in public health measures, but also the impact that medicines have in terms of increased survival at a younger age to improve vaccination, and obviously the socioeconomic developments which are enabled people to live longer. However, one of the things that we know is that non-communicable diseases is increasing, and that as we age, we need to make sure that we age well. And that's well known that although people are getting older, they're not necessarily living well for longer. And medicines can be a contributing factor, particularly when people have many long-term illnesses and many medicines as a result, to manage all of those to ensure that they don't cause harm. So as you can see, is that many people live with many long-term illnesses. So multimorbidity is common. And you can see that you don't actually have to be very old to have more than 2 long-term illnesses. What we also know is that in areas of deprivation and poverty, we find that multimorbidity or long-term conditions will occur 10 to 15 years earlier. So we may need to think about these individuals that are going to need to use multiple medicines much earlier in their lives. So we need to bear that in mind. So we're here to talk about polypharmacy, but what is polypharmacy? And many research papers use numbers to define a threshold for polypharmacy and to benchmark. But really what we need to think about is the polypharmacy causing harm? So it's where it's more medicines than a patient can handle that are causing harm. They're not going to get benefits, or they're not able to take it. And polypharmacy, so the increasing number of people taking multiple medicines, is a problem globally. And you can just see some figures here, and they are on the rise globally. So rather than focusing on the number, as I said, we need to focus on, is it appropriate? And appropriate polypharmacy is present when all the drugs that are prescribed are achieving the specific therapeutic purpose for which they were given. So an individual is going to be able to take it for long enough in order to achieve the benefit, or it's achieving the target changes in biochemistry that we've been looking for. For example, an individual could be taking 13 medicines if they have had a myocardial infarction, have diabetes, and these medicines may be completely appropriate. However, compare that where inappropriate polypharmacy is present, when one or more of the medicines that are prescribed do not have good clinical evidence, are no longer needed. So here, an individual could be taking just 2 or 3 medicines and it's causing them harm. For example, somebody that's taking a non-steroidal anti-inflammatory drug and it's causing GI irritation and discomfort to the point where you have to prescribe a proton pump inhibitor to counteract that effect, and that non-steroidal was probably not indicated. So it's thinking about the appropriate choice. And we all know that clinical evidence changes over time as well. So maybe at one point something may have been appropriate according to the clinical guidance, but as this gets updated and changed, it may no longer be appropriate. So reviewing medication is important. And this, again, is, I'm sure, something that many of you are familiar with. The medicines that you see on the right-hand side are from one patient, all laid out of medicines that have been piled up and not taken by the individual. And the data on the left-hand side is national data from Scotland showing the number of people taking multiple medicines. And you can see that people are not very old when they're taking 6, 7, 8 different medicines, and they may be taking those 2 or 3 times a day. So the burden of that on the patient is high. One of the possible causes of polypharmacy is also something that's known as a prescribing cascade, and I described that a bit earlier, where it might be that there's an adverse drug event that's misinterpreted as a new medical condition and a subsequent therapy is prescribed for treatment. And this can be for multiple medicines, and it can contribute to additional adverse effects. For example, sometimes when we prescribe calcium channel blockers, we may get oedema, and we may then prescribe a water tablet, a diuretic, to counteract that effect. And so this prescribing cascade in many areas can contribute to increasing the number of medicines an individual is taking. We also need to take into consideration when we talk to our patients about the treatment that they're on is medicines that they are buying for themselves. And we know that this can be a problem and a challenge if they go out and buy medicines themselves from the pharmacies, but also that they may also be taking traditional treatments that may also have an effect on the medicines that have been prescribed. And as people get older or they have many long-term conditions, we need to factor in frailty as well, because changes in physiology will mean that the bodies will deal with the medicines less effectively and therefore increasing the likelihood of harm. So this is some data across Europe that showed that many medicines-related admissions result due to polypharmacy. So unplanned hospital admissions, about 11 to 17% of all admissions to hospital are caused by medication-related harm, and half of these are preventable. And 70% of these occur in people over the age of 65 or more taking 5 or more medicines, so not very many medicines. And a document that's been published about how to manage polypharmacy is shown here on the left-hand side, and you can access that document. But it goes through the principles that need to be in place in order to address this public health challenge. And we should be reviewing this every time we go to start a new medicine, but also when we regularly review medicines at medication review. One of the things that we do need to consider is that we know that there is an increasing likelihood that climate change is going to have on human health. But we also know that the medicines that we use have an impact. So, for example, medications such as inhalers can have an impact on the carbon footprint and therefore in turn affect the climate. So it's really important that the choices we make around medicines also take into account environmental considerations. So at what point of a patient's journey should we think about polypharmacy? So the key areas here, and the key areas that tend to cause medication-related harm, are prescribing and monitoring. So at the point of prescribing, this is where we can minimize any further inappropriate polypharmacy, but also that we monitor so that we know that if we prescribe a medication, that we also review it. It's not to say that errors don't happen at these other stages, but these are the highest areas of risk that we need to make sure that we address it. And we know that as prescribers, these are some of the areas that can cause harm. And as you increase the number of medicines, there's an increased likelihood that you'll get some of these errors that are highlighted. And as different healthcare professionals expand their professional roles, we know that there may be a crossover of the causes of medication errors that result. So one of the things that I want to talk to you about is the polypharmacy report that was developed, and had the privilege of leading the writing of this document. But we also know that people taking maybe 2-3 medicines can be at risk of harm. So this clinic that we took place in rural Uganda identified women that were taking maybe 2 or 3 medicines, and when they were taking these 2 or 3 medicines, they were on medicines that were causing side effects that were no longer appropriate, and tragically they were making decisions about taking the medicine or eating, and it was important to make sure that we stopped the inappropriate medication. So the way to address polypharmacy and to make sure that it's appropriate is to take a person-centered approach. And you have the link here that you can access and download the app onto your devices and access the document through the internet as well. But the key important thing is that before we initiate treatment and when we're reviewing medicine, we find out what's important to the individual. What is it that their goals are? Because sometimes lifestyle changes can be implemented to prevent the need for medicines use. if we decide that a medicine is to be used, we need to make sure it's the right treatment and that no unnecessary treatment is being prescribed. So at this point, we need to review all the medicines an individual is taking, both prescribed and ones that they buy for themselves. We can then check that the medicines are effective. Are they doing what we thought they were going to do? And if not, we might want to change them and stop unnecessary medicines. Checking with the patient if the medicine is doing any harm is also important, and to make sure that it's both environmentally the most friendly product, but also that the patient can afford and maintain treatment with the product that you're giving them. And importantly, we start with the patient and we ask them what matters to them, but it's important that we agree and share the plan with them. We know that up to 50 to 80% of patients taking 4 or more medicines don't take them as prescribed. So even if they have the list of medicines and they're all appropriate, we need to make sure that they are equal partners with us in making the decisions and agreeing to take the medicines. And what you see in the middle is 5 moments of medication safety, where patients can get involved in asking key questions about their medication journey and thinking about when they're starting the medication, how to take the medication, and what checkpoints there should be if a new medicine is added in, which would lead to a review of the medications an individual is on, but also consideration when it might be appropriate to stop a medication. And what we have in this tool that I provided the link to is a patient app, which provides tools for patients and carers about how they can access information, how they can store a list of their medication, so that as they go to different healthcare providers, they can share that information. And as I say, you can access it through the QR codes that are shown here. So the important thing is to take a person-centered approach, to make sure that the patient is involved in the conversations, and you make the decisions to ensure that you review treatment that's been prescribed and that it's appropriate, so that we stop any unnecessary medicines. So that's the driver of the reviews. It's not about deprescribing. We will deprescribe if it results that the medicine is unnecessary or it's not effective. So there was the European work that we did looked at many EU countries of different healthcare systems and different wealths. And we used the key findings from this European project, and the 6 of them are shared here with you. And we took those 6 key recommendations to implement reviews across further 3 EU countries at scale, reviewing over 6,500 patients. But the important aspects here that I really want to draw out is that it's really important to have a culture that encourages and prioritises patient safety and allows different healthcare professionals to talk to each other about prescribing and appropriateness, but also to involve patients, making sure that clinicians work with policymakers in order to design systems and using data to drive that change. And whilst the evidence is still emerging on polypharmacy, there's enough there that tells us that we can take action to improve the safety in this field and to make sure that the tools are widely shared. It's important to undertake in your countries a PESTLE and SWOT to identify where the potential barriers might be, but also where the enablers might be. So what politically, what publicly would benefit to ensure that policies around addressing inappropriate polypharmacy can be implemented. And indeed, the Sympathy Project found that these tools, where they were used, the countries had more effective systems in order to address inappropriate polypharmacy. So it's important that these are thought about and contextualised to the country to identify what the issues are. And I mentioned before about poverty and deprivation, and indeed analysis of national data here again shows that the people that were most deprived had multimorbidity arising much earlier, and they were taking medicines earlier. So when we're planning for services, we might want to target people taking medicines much earlier if they're in a deprived population. So it's difficult to think about doing this for everybody when we have a big population. So how do we prioritise the care that we may need to ensure that the people that most need the polypharmacy reviews are the people that get these reviews? So another report that was published alongside the medications safety in polypharmacy was the medication safety in high-risk situations. And so what we can do is identify the key medicines that are known to cause harm, the high-risk medicines when they're used inappropriately, and the acronym APINCH is used. And what you can do is to take this list and look at it in terms of your institutions and find out which ones are causing the harm. Where are you having the issues and the problems in terms of patient side effects or reactions that are putting the patients at risk of potential hospital admission? So you can access some of that information, but we know that many people also access care in primary care, and there's a link there to a document that will highlight the key areas, the key medicines which overlap that are true for primary care. So if we take a case and look at how these all things fit together, if we think about Mrs. W, she's a 58-year-old, she's got a history of asthma and COPD, and you regularly dispense inhalers for her. Recently, you notice that she's not been herself and has bought some over-the-counter remedies for her back pain, cocodamol, which is a combination of paracetamol and codeine, after falling off the pavement a couple of months ago when the weather was bad and the ground was slippery, so she fell in the rain. The pain has stopped her doing her normal activities, and she tells you that she's looking for some anti-inflammatories and something to pick up her mood and her sleep. Her friends told her that ibuprofen would help her, and she's been taking these for the last month, and she presents a prescription for omeprazole for indigestion and heartburn. So if we look at how we might use these documents in order to address inappropriate polypharmacy for this individual, it's important that we make sure that there are many high-risk medicines that are being bought for this lady that's taking multiple medicines. So there's an opportunity here to intervene in what's causing harm. And we know that by addressing that, we can prevent possible hospital admission that might result if this lady had carried on, because there's multiple drug interactions here. And as the lady moves from different care transitions, it would be important that we have an accurate list, which can be difficult. So sometimes patient health lists might be effective in addressing that. So one of the outcomes from the iSympathy project, looking at the management of polypharmacy and adherence through the years, so looking at it across the age ranges, was looking at the outcomes from over 6,500 patient reviews. And through taking a person-centered approach, what it found is that the appropriateness of medication improved in 92%, and there was a reduction in the number of medicines that people needed to take, but also patients had a better understanding of the medicines, and many of them felt that the medication review improved their outcome. And you can read what a patient put down in terms of how they felt after the change in their medication. Importantly, of these interventions, 82% of them were rated as being clinically significant, and it was an economically viable model. So it's thinking about how do you prioritise these people for review, and we've seen that we can do that by identifying patients that are taking high-risk medicines that may benefit from a review. And consultants feel that by taking this approach, it's made a significant change into how they use medications and review medications for individuals. And again, if you have data available, it's important that you use the national data sets in order to drive improvement. So you can see on the right-hand side, high-risk combinations nationally, the numbers of people taking the high-risk combinations that put people at risk of acute kidney injury can decrease if you target people taking any of those medicines. And it's important that we empower patients and their carers so that if they do fall ill, they know what to do when they're when they become unwell. There may be certain treatments that they need to agree with their prescriber that they may need to withhold for a short period of time, and it's about having those conversations and preventing harm. What countries often ask me is this economically viable for us to do, because it's time consuming to do the reviews, and what are the benefits? So economically, the evidence shows that many of the interventions that are made, the reviews done in collaboration with multi-professional teams, with doctors working with pharmacists, that there are improvements in the patient care, a reduction in, for example, drug interactions, contraindications, but also as a consequence, the outcome is economically viable. And you can see just 3 papers here that are highlighted with particular programs, and they're the ones that are highlighted here, some done in a care home setting and others delivered by community pharmacists. So it's how you might involve the wider healthcare team, and you can access further detail in the references given. So we need to think about, if we're going to address medication safety in the context of polypharmacy, it's to think about what harm may have been caused and which particular medicines may be contributing to the harm here. And is there any way that we can monitor it consistently? And how good are we at picking up any errors or problems that occur? So even if we do it at institutional level, are there areas that we've noticed that we have certain problems with? And it may be that we know the list of high-risk medications. So can we use those medications to form a list that we target and prioritize those people? And if we do have alerts that identify errors, can we then share that learning? Because it will be important that we share learning as we implement, so that we can identify practices that other people may want to adopt, or areas that other people may want to ensure that they prevent the harm arising from. So it's trying to think about how are you going to benchmark, how are you going to get a sense of what the key problems are. And as I say, these are just some metrics. So one other high-risk medicine that I know is a problem globally is the use of gabapentinoids and people becoming potentially dependent on them when they're prescribed for the management of pain. So again, it's making sure that we look at our data, or we see if we're increasing the number, but also thinking about how we review these patients to prevent unnecessary treatment. And here again, this is a combination which again is implicated in acute kidney injury, what we call a triple combination of 3 medicines used together. So one way to do this in your organisation without lots of data is to do a point prevalence, so to find whether it's a hospital setting or an outpatient clinic, is to look at when people are coming for care, are they coming for an area that's potentially associated with medication-related harm? Although they may have come because of breathlessness, for example, has that been triggered by a medication, for example, that's been used in combination? And thinking about how long you might want to do it for, over what time period. So point prevalence data may help give you some information around benchmarking data. So thinking about your list of high-risk medications, thinking about if you do identify it, how are you going to monitor it? Which medicines do you want to start with? It may be that you start with some high-risk medications, and you need to think about how you might put information on the labels of some of these medications and how patients might be counselled in order to identify if there are areas of particular risk to them. So there is some training material that has been produced. It is in English, but it can be accessed to go through the relevant training on appropriate polypharmacy use. So one of the decisions that we know that we need to take is when we're thinking about whether the person is going to benefit from the medication. And this is known as thinking about the numbers needed to treat. So how many people need to be treated in order for a medication to be effective. It's then thinking about the individual you have in front of you and how applicable the drug trials are to that individual that you have in front of you, but also in the context of multimorbidity and frailty. And so these are important tools that are there to help frontline practitioners really make those decisions about whether the medicine is going to benefit them or not. So here, this is what I was saying before, is that we know that many medicines are not taken as we intended, and we know that many medicines can be wasted as well, that we end up putting many medicines either back to the pharmacy or we dispose of them, and it's making sure that there isn't that unintended consequence of polypharmacy, as well as thinking about the medication safety aspect of it, because that can cause harm as well. But also when patients don't take the medicines as intended, we know that people often keep the medicines and then maybe share the medicines, which can add to an individual's list. In Scotland, every day we destroy 1 ton of medicines each day, and this has a detrimental effect on the environment. And if you multiply that impact globally, you can see the impact that this can have. What some countries might want to do is they may want to target doing polypharmacy reviews in particular therapeutic areas. So say, for example, we might want to look at it in the context of respiratory care, thinking about at the moment, we might see that we have a particular problem around management of respiratory conditions. So we may want to focus on optimizing polypharmacy in that context. So people may take multiple medicines, and whilst we're focusing in on the respiratory medicines, we need to make sure we review all of them to make sure that they're not doing any harm. And one of the common areas in terms of patients with respiratory diseases is that they don't use the treatments appropriately. So, for example, many people with asthma will use lots of relievers rather than using preventative treatment. But it's also thinking about the resulting hospital admissions and the resulting deaths. So we know that overuse of reliever inhalers is associated with respiratory deaths, particularly with asthma. And if we could address the appropriate use of these medicines, we may be able to support an individual having to go to hospital, and it has a huge impact on the individual, but also on the environment as well, as they have to go into hospital and deal with the consequences of an admission. If we then look at another area that typically is associated with polypharmacy is type 2 diabetes, because we know that with type 2 diabetes, we're not only dealing with improving the outcomes around blood glucose control, we're also thinking about renal and cardiac outcomes. So it's likely that these individuals will be prescribed many medications. And we know the treatments in this area are changing. So we know that that these will need to be reviewed and improved. And here again, you can see that we want to start off by thinking about non-medicines interventions first that we may be able to suggest to the individual in order to address their type 2 diabetes. We need to think about mental health and the impact that might have on how individuals manage many medicines, and also the consequences of frailty that may also result, particularly if they develop chronic kidney disease. So thank you very much for listening. I'm open to any questions that you may have on addressing inappropriate polypharmacy and medication safety in polypharmacy.
Thank you, Dr. Albana. We are now going to begin answering the questions submitted during today's presentation. As a reminder, you still can post your question in the Q&A panel. Dr. Albana, this is the first question. The question said it's from Dr. Rakan Al-Mughir. He's saying he's reading a research about pharmacy lead anticoagulation clinic and how they improve the complaints and decrease the adverse event from anticoagulation. He is asking, do you think from patient safety point of view and cost effectiveness, it's possible to deploy other pharmacist lead clinic for common diseases?
Yes, I do. Thank you for that question. That's an important question. So there are a couple of slides that in there that look at the cost effectiveness model of having pharmacists as part of the multidisciplinary team in terms of improving safety, and that's been replicated many times. So, you know, quite far back, the Institute of Medicine's published a report in terms of addressing medication safety, and they estimated, £18 billion wasted or consequence of harm caused due to inappropriate polypharmacy. And one of the things that they suggested then was having pharmacists as part of the multidisciplinary team, working with the doctors in order to improve medication safety and improve outcomes from medicine. So there is evidence there that shows that it's a cost-effective model, and it does need requirement, though, I would say, to think about some of the strategies in how you enable honest conversations so that different healthcare professionals can work together effectively. I hope that answers the question. Yeah.
Yeah, thank you, Doctor. Also, we have another question from one of the audience. What is the patient role will be in addressing polypharmacy?
Yeah, no, thank you for that. So I think it's so the 5 moments of medication safety really asks the patient to think about them understanding what the medicine is for, but also asking the questions if they experiencing harm. One of the key areas around undertaking a person-centered review is it's really up to the clinician. The clinician could be the doctor, the nurse, the pharmacist, but involving patients in the decision making about the benefits that they're going to get from the medications. So I think patients' role is to identify that they understand what the medicines are for them to be able to talk about the medicines that they're taking, not only that the doctors prescribed to them, but they've bought, because that even the medicines that they bought might identify possible harm that's resulting from medicines that have been prescribed. For example, people buying antacids to try and counteract the effect of medicines that are causing GI irritation. So I think that that's a key role for patients, but I think that many patients are afraid to talk to healthcare professionals, or they don't feel that they can talk about if they don't feel comfortable. So I think there's something there for us as healthcare professionals to encourage patients and ask them how they feel and what they think about taking medicines and the risks and benefits of them.
Thank you, Doctor. As extension to the previous question, how will a different healthcare provider will work together to address this issue?
Yeah, so I think it's important that once you identify that you want to address inappropriate polypharmacy in your organisation or in a region, is for the different healthcare professionals to come together and to discuss the role that each of them may play and how they are going to address maybe past prescribing that maybe needs to be changed. So thinking about the quadruple aim that thinks about improving the outcomes for individuals, but enabling the healthcare professionals to feel safe that they can speak up if they see that a medication isn't appropriate anymore. And I think that's most effectively done by people coming together from the different professionals to design how they're going to deliver the reviews. So who's going to do the majority of the reviews, and how are the actions and the recommendations from the reviews going to be implemented and addressed. So it's important that that's done collaboratively, but also that involves educators and policymakers that will give people the skills and enable them to fulfill those functions. So in some countries, I know that there may be the need to change laws or to look at policies to allow different healthcare professionals to adopt new roles. So it's thinking about that as well.
Thank you, Doctor. So our fourth question will be, how can we avoid polypharmacy in the absence of a unified patient files?
Yeah, and that's a challenge that many countries face, even those that do have quite good healthcare records, because having that one complete medication list can be quite a challenge. So one way might be to ask patients themselves to hold a list. So it may be, obviously the app that I shared with you is one way to have an app that the patients can enter and hold their own list, but to capture on that any additional medicines that people are taking as well. So if they're buying medicines, to enable them to hold that list. I think once you have that list, if that's shared with the healthcare professional in the setting that the patient accesses a healthcare professional's advice, that we can look at that list and identify medicines on there that are high risk. So, for example, we might want to say, make sure that people have appropriate knowledge around the appropriate use of non-steroidals or opioids, but it's about supporting people to keep that list in the absence of a unified health record.
And our last question, Doctor, is in the absence of medical records, especially in community pharmacy, and a lot of patients are taking medication from community pharmacies and herbal medicine, vitamins, and etc. And with this issue, it will be more difficult to handle polypharmacy. And what's your advice to handle this issue through the community pharmacy?
Yeah. So again, I think that there's a role here for the community pharmacy to have the ability to just ask the questions of when they're coming to buy medications, to really just sort of ask and say, you know, what medicines are you taking, so that I can check the safety of these medications with the ones that you want to buy. So there's something there about the policy in the different countries in requesting that that's what the community pharmacists do. It's something also, though, that I think and relates to one of the questions that you asked me earlier, is what's the patient role? So I think that there's something that can be done around raising public awareness around some of the consequences of taking multiple medicines. And the WHO has a good campaign, No Check Ask, so people know what they're taking their medicines for and they can ask the questions. So I think that it's important for people to be able to share that list that they may hold with the community pharmacies, so the patients and the public needs to be encouraged to do that as well. And I think that might allow more interventions from the community pharmacy to provide advice on whether the medicine that they're looking to buy is suitable or not.
Thank you again, Dr. Albana, for answering all these questions and for the great presentation. It was a pleasure to have you with us. So this concludes our today's webinar, Medication Safety on Polypharmacy.
Thank you.
Thank you. On behalf of Saudi Patient Safety Center, WHO, IMRO, and our presenter, thank you for joining us today. We hope you have learned and enjoyed our presentation. Have a great rest of your day. Thank you so much.